Anders from Nairobi, Raj Mandavia from Kisumu, Amina, Garissa County, Eric, Nakuru County, Paul Muranga, Purity Kisumu, Evans Busia, Patricia. Hi, Patricia. Where are you joining us from? I'm seeing Sudan, Vihiga. So we have a good representation as well. We'll give it one more minute before we start. And we'll start at exactly 7:05. Nakuru County, Embu County. I'll also ask my panelists to turn their video on when we start. I can see Istanbul. I can see many Kisumu counties. I wonder why. Focus on Kisumu County. I can see our panelists have joined. Dr. Ganda, Dr. Chemtai, Dr. Marion, Dr. Baraza, Dr. Kiriki, we're still waiting. Okay. Okay, we'll begin now. I can see all the panelists are on board. And please continue sharing where you're from, your name, would like to hear from you. But thank you everyone for joining us this evening, Thursday, 30th January, on this very important conversation around cervical cancer. It has been Cervical Cancer Awareness Month, where the theme was empowering prevention and early detection. And we're focusing on how do we ensure that cervical cancer screening services are part of universal health coverage. And today we'll spotlight on Kisumu County. A few housekeeping rules. So we will have the panelists speak for about 10 minutes. We'll have Dr. Myron, who will be my moderator. I'll introduce her shortly. Take the panelists through some of the questions that have come in as well. And once the panelists are done speaking, we will take a few Q&A questions from the audience. I'm asking you if you do have a question, whether it's very specific to a panelist or a more general question, there is a Q&A section in which you can type those questions and we'll be able to respond to them. I am requesting that if you could address specific questions, you could address your questions in the Q&A section, just because we might not be able to pick them in the chat. So if you have a question, write them in the Q&A section. For some of the questions, we'll be able to ask live. And so the program for today will start off with Dr. Marion, who will introduce the different panelists, then the Q&A section, then we will have closing remarks by a special guest. I'll not reveal who it is. And then we'll have the way forward by Dr. Chris Baraza. Dr. Marion, you're there with us?
Yes, Dr. Diana, I'm here. So,
okay. Yes. You don't want me to sing your praises by reading your bio, which it's quite a lengthy one. Yeah.
Make it short. Make it short.
How do you do that? But no, Dr. Diana Marion is an obstetrician gynecologist. She's also our boss at Kenya Medical Association, or our Secretary General at Kenya Medical Association. And she does a lot of advocacy work in addition to clinical work. I know she's been a big champion in the counties. I'll not mention which one, but she has been a big champion for cervical cancer. And her work is well known locally, regionally, and internationally. That's as brief as I can get. Dr. Maron, I'll hand it over to you for welcome remarks and to introduce the panelists as well.
Very good evening to all guests. A very good evening to the panelists. And a very good evening to Dr. Diana. Thank you for introducing me, and I want to welcome you all to this discussion, a very important discussion. I always say that cervical cancer is close to my heart, mainly because this is one of those cancers that affect women, but it's purely preventable. So if we preach the gospel, or if we actually move tables to ensure that we can prevent this cancer, then we will get somewhere. So I want to really bring it out in terms of, we have statistics, but I don't want you to think about statistics. I want you to think that those statistics actually represent lives, they represent stories, they represent battles. And we have seen all these as we practice what we do. We have seen this with our relatives, and we have seen this with people who live with us. And we really want not to see the really sad stories, and we want to see success stories. And this has already happened elsewhere in the world. And we know it's a story that Kenya can have. And therefore, joining us today are important people that will be able to tell us good stories. They'll be able to tell us the plans, the strategy, the policies. They'll tell us the advocacy part in terms of what they do, and they will also tell us what they really think we can do to move this conversation faster and move this conversation to the right direction, make this conversation be within UHC, that's universal health coverage, make this conversation within primary healthcare, and make this conversation something within our budget, and something that we can really, in another 5 or 10 years, it's a conversation we are putting in our past. So I want you to join me in welcoming Dr. Elias Meli. I will introduce the panelists in no particular order, but I want to introduce Dr. Elias Meli, who is a medical doctor. He is a medical and radiation oncologist with extensive experience in patient care, research, training, policy at local, regional, and global levels. He's the current CEO of the National Cancer Institute of Kenya. He holds a bachelor's degree from Moi University, a master's degree in clinical oncology and nuclear medicine from Alexandria University. He also holds a Master of Business Administration and a Master of Public Health. Before joining the National Cancer Institute, Dr. Meli worked in public and private sector as a technical and a senior management level. And he has worked in various hospitals. He has spent cumulatively 2 years with different NCI designated cancer centers in the US. And I really want to welcome Dr. Elias Meli. I want to also welcome Dr. Ganda. Dr. Gregory Ganda is the CEC, Public Health and Sanitation from Kisumu County. It's very important to highlight that today, this conversation, we are actually going to put a spotlight on Kisumu County. And we want to hear, what is it that Kisumu County is doing? What is the good about it? What is it we can improve on. So Dr. Ganda is a seasoned administrator with 18 years of experience. But what I would really like to highlight that he's actually a trained gynecologist. And a gynecologist is someone who treats and deals with cancers of the female reproductive tract. And therefore, other than him being in the administration, he's actually a trained specialist. And I would want to welcome him also, and he will tell us a lot about the work he's doing in Kisumu County. Our other panelist that I would like to welcome is our president from the Kenya Obstetric and Gyne Society. He is a senior lecturer at the University of Nairobi, Department of Obstetrics and Gyne, and he is also been involved a lot in projects around reproductive health, and keen to say he leads an organization where we can make great change when it comes to women's health. I would also like to welcome Ms. Sela. Ms. Sela is a registered nurse and a seasoned public health professional with extensive experience in managing complex health programs, project development. Experience includes strategic development and strong program management. She holds a diploma in nursing, a degree in health system, and a master's in community health and development. Ms. Sela is currently the County of Kisumu Cervical Cancer Coordinator, and she works within the County Department of Health, providing overall coordination of cervical cancer services in the county. Finally, and as I said, it's not in any particular order, I want to welcome Dr. I think, Diana, I'm trying to intro. Yes. She has a very long profile, but I will make it very short, and I'll be very specific to the research that she has been doing. So Dr. Mungo is an assistant professor of obstetric and gynecologist and a physician scientist at the University of North Carolina. She earned her medical degree from the University of California, San Francisco, and a master's of public health from Johns Hopkins. Her research is focused on improving secondary prevention of cervical cancer in low and middle income countries. Specifically, her interest is around the feasibility of self-administered intravaginal therapies for HPV and cervical precancer treatment. She has been recognized as a young investigator in areas of clinical oncology. And as I said, her CV is really around cancer and women's health. And she's a health advocate around key issues that affect women, especially in Kenya and Africa. So I think I've not left anyone out, Dr. Wangare. I really want to welcome our panelists, and we can start this discussion.
Absolutely. Thank you so much, Dr. Myron. Karibuni, our panelists and our participants. I encourage you to, again, drop us your name, tell us where you're joining from. If you have any questions, please write them in the Q&A section, not the chat section. We will, Dr. Myron, I believe you'll be beginning the questions to our panelists. I can see Dr. Elias Melly is perhaps not here. There he is. I believe, Dr. Myron, I'll hand it over to you. Dr. Melly is online as well. You can take it away.
Dr. Melly, welcome again. We have some questions, and we really want to highlight these questions, key towards issues of cervical cancer prevention. And the first one is Kenya has a national cancer control strategy, yet we continue to see low HPV vaccination and screening rates. what are some of the policy and systemic challenges hindering the success of these programs, and how can they be addressed?
Well, thank you very much, Dr. Diana Marion. Glad to see you moderating this session. Dr. Diana was my classmate in medical school, so really happy to reconnect in such an important session. I would want to appreciate the organizers of this webinar and join my fellow panelists in doing justice to the topic that we are discussing today. I wish to also appreciate that there is no better time we could have this discussion than today, when we are culminating our cervical cancer awareness month, which has seen a lot of activities across the country. I must begin by recognizing that as a country, we are faced by many health challenges, just like there are many other challenges beyond the health scope. But cancer has become one of the leading public health challenges and a real public health burden in our country, and would appreciate that our government is very strategic in addressing this challenge by making sure that it leads the way, not only addressing the cervical cancer challenge, but cancer in general. And one way that our government demonstrates commitment through Ministry of Health is government policy directives and establishments that have been created to make sure we have a very dedicated strategic way of addressing cancer. One of them saw establishment of the National Cancer Institute of Kenya that I currently lead as the director and the CEO, and happy to be part of the panelists today. There is a rising burden of cancer. We talk about statistics. I know our moderator had mentioned that beyond statistics, we need to see initiatives turn into action and actually have an impact. But to begin us off, data gives perspective and demonstrates the burden. Every year in our country, more than 44,000 cases are diagnosed. These are estimates as per Global Can Data 2023. And of these, approximately 6,000 are cervical cancer cases. And unfortunately, more than half of these patients die within 1 year. A mortality rate of more than 55% is worrying. And this is cumulatively as a country, but if we were to break it down across the regions, the statistics would be otherwise different. The Ministry of Health developed a national cancer control strategy, which is currently implemented by the National Cancer Institute of Kenya. And this is a strategy that was developed by all the stakeholders in the cancer space, many of them who are in this webinar today, and we really appreciate a very beautiful document that we are implementing over the next 5 years. This document has 5 pillars. Pillar number 1 is on prevention and early detection, and we have pillar number 2, which is on diagnosis, pillar number 3 on treatment, number 4 on coordination, resource mobilization, and partnerships, and pillar number 5 on research and data surveillance. Of relevance to this webinar, we are discussing about cancer prevention, cervical cancer to be specific, and early diagnosis, very relevant discussion. No woman actually should die of cervical cancer in a country, a purely preventable disease. I struggle many times when I sit in the clinic to give a perspective when I see a lot of our patients with cervical cancer present devastatingly, and unfortunately, some of them lose their lives for a disease that is purely preventable. We, over the last 6 years, rolled or launched the call towards elimination of cervical cancer as per the WHO guidance, the 90-70-90 strategy to eliminate cervical cancer by 2030. We have targets. And the experience we've had over the last 5 years has been not so promising, especially due to the many challenges we have faced in vaccinating our girls between 9 and 15. Our Kenyan policy is 9 and 14 years in our country. And some of these challenges, specifically now to respond to the question from our moderator today, we have a huge challenge on information dissemination across our country. We've had an opportunity to assist our county governments to provide technical assistance in developing every county cancer action plans. And one of the indicators that we were discussing was how is the uptake of HPV vaccination per county. You'll be very surprised that in our country, there are counties who the uptake is extremely low, less than 10%. And others have done fairly well. And we did realize that one major challenge is information dissemination. There is a lot of ignorance within our country. There are also cultural barriers. When we got feedback from our county governments, there are so many beliefs that HPV vaccination is likely to cause infertility amongst our girls. So a lot of fears and worries from our mothers, parents, to our daughters, and that has been another significant barrier. We also have a challenge in terms of coordination, proper coordination of this exercise, from the national government to the county government, so that there is, an efficient way of reaching out to all our girls. We do also have lack of evidence from data, to convince, the public that actually, if you get HPV vaccination, it's going to prevent cancer. The reason why I talk about this is because, the process between mutation as a result of HPV infection to when cancer presents clinically is a very long process that someone may not understand, at that early level, that it is actually a prevention strategy, since we know carcinogenesis is a very, very long process. Of course, we also need resources to make sure there is a well-coordinated system towards addressing this challenge. So funding also to facilitate the entire process is very important. There are solutions that we are proposing and working with all the stakeholders in the space. The beauty with cancer care in a country and in any system, it is a matter of everybody. There is nobody who is not involved in, as a stakeholder in this cancer space. With having the opportunity as NCI to coordinate all the players in the cancer space towards one vision of cancer-free Kenya, towards our mandate in cancer prevention and control, we have appreciated that everybody is a stakeholder within the public, within the private sector, within the NGO world, locally, internationally, amongst our patients, civil society, and everyone else, many that I've not mentioned. So working together, our solution really surrounds strengthening the health care system to make sure that the community reach is impactful. We do appreciate initiatives which includes community, health promoters who have done a very good job in mobilization, in education, in patient navigation. We need to make sure we empower the public through education, and the activities that are ongoing, albeit slow, but over the next couple of years, we should be able to aggressively make sure the public is informed. And better coordination now through the National Cancer Institute of Kenya is taking shape. where we are inviting all the stakeholders to work with us so that we work with them and we jointly work to deliver. We have a technical working group to deliver on this pillar one of cancer prevention, and cervical cancer being, one of the leading cancers amongst women, takes a center stage as well. So proper stakeholder engagement and management and coordination is very important. I must also mention that research and development, is key as an initiative to address this challenge. Implementation science research. We already know we have an intervention through HPV vaccination, but then how do we move these from science to clinical care, where we actually administer the intervention and allow time to see how this would change the landscape. We also had a challenge of the 2 doses vaccines 6 months apart. When we had the county engagements, we found out that the uptake for the first dose was very good, but the uptake for the second dose was quite a challenge. And now we are happy that, through evidence, through research, that as a country we also participated, we do actually now can, administer single dose and it has the same efficacy. And this would cure the challenge that we've had about low uptake for the second dose, especially where there is no motivation for to go back for the second dose after the first one, because these girls do not have any disease they are treating. It's just, modulating their immunity to be strong to fight against HPV infection in future. So we are happy that as a strategy, this will definitely make a whole lot of a difference. As a government, through the current government flagship project of making sure UHC is a success in the primary healthcare pillar, where there is a lot of community engagement through the community health promoters, and also funding at the primary healthcare fund. There is a lot that the government, through policy shift, is considering as we get resources going forward to make sure that HPV is fully administered. At the same time, there is going to be reimbursement to our facilities for those who would be presenting themselves for screening, for all cancers that are screenable at this time. So there is policy shift, there is support, there is goodwill. All that we are working on right now is to making sure the stream of funding is available to ensure that we address this challenge. Allow me, Dr. Diana, to pause, and probably as we carry along, we can discuss further. Thank you very much. Well appreciated.
Thank you, Dr. Melly. I think what you're telling us is we have goodwill, we have plans, we have policies, and we are actually working as a government to really make sure that the strategy is a success. We are also working around the challenges. And I think it's very important that we are looking at integrating this into primary healthcare and making it actually work. I think we've also had some challenges around those changes, and we are really hoping that your team will really look at that and make it easier for our women and girls to be able to have access to preventive and screening services. So I want to really move quickly to the president of the Kenya Obstetric and Gyne Society. I hope he's here. Dr. Kireki, are you with us?
Dr. Myron, he's not with us. I think we will do the spotlight to Kisumu County, and then he'll join us.
So we will move to Kisumu County, and I think one of the reasons we picked Kisumu County is that they are actually doing a lot of work on the ground around this same conversation we are having today. And we really want to hear, because we would want to see this replicated in the other counties and even in the country at large. And the three speakers, that is Dr. Gregory Ganda, Ms. Sela Owor, and Dr. Chemtai Mungo, are likely to give us conversation around what is happening. And I would really like to start this conversation with Dr. Gregory Ganda, who is the County Executive Committee member and Public Health Sanitation Kisumu. And I want to really put this straight to you. Counties play a very important role in the implementation of cervical cancer programs. What are some of the biggest challenges that you have seen, especially when you're trying to ensure widespread access to screening and treatment services at the county level? And while at it, I would really like you to also address issues around implementation of the cancer screening and treatment services towards achieving UHC, and what are some of the strategies you have put in place to achieve this? Welcome, Dr. Ganda.
Thank you. Thank you very much for that kind introduction. As you've already been told, I'm in charge of the Department of Health in Kisumu. So you asked me to talk about the challenges that people face in getting cervical cancer screening, but I think that some of them have already been mentioned by Dr. Meli, starting from the individual themselves, that we have many beliefs. Some of us, I think Sela will talk greatly about it, so I don't want to repeat that. But one of the things I want to mention is the issue of whom do we screen. Most of the time, we have spent our time screening people who walk into our facilities. And most of those people are sick people, or they have a problem. They have a big headache, have abdominal pain. And so we want to take opportunity to screen you. And we know very well that quite a big percentage of people don't walk into the facility at any one point in time. And so we concentrate on the few who come, and we screen them many times, and we leave out those who don't walk into the facilities. And of course, I've always asked people, if somebody walks into your office and then you ask him that, okay, I want to do an eye check on you as you wait for Dr. Ganda, most of the time people say, no, I'm not interested. And so it's not really strange that many people don't opt for that screening. Secondly is the cost of the test. Whenever you are put up a cost, many of our people will not be able to afford that cost of the test. The third is the personnel. Not all our personnel are trained on cervical cancer screening. And many times we send the most, what do we call it? The least experienced person to the communities, onto the health centers and dispensaries. And so you train them on 1 week and expect them to be experts on the field. And of course, that means then they avoid doing it, not because they don't want to, but because they don't feel comfortable doing it. Third thing is the distance, and I'll show you it is quite long, because if you're going to look for somebody who is doing screening and you have to travel quite some distance, then it becomes a problem for you. Some people have to travel 50, 60 kilometers, and this is somebody who is not sick, you're just okay, and somebody tells you, travel to have your screening done. So that becomes a problem. And finally, we don't treat everyone who comes. Telling somebody that you have a problem in the community, and then we tell you you will need to travel to go get treatment. I've screened you, found something positive, but then you travel by. Next time you will not want to come back to that facility. And that gives us negative connotations. So you can put up the slides now. I would like to use some slides because sometimes it is better to speak through them. Please put them up. I'll just talk about our experience in Kisumu, and the first slide is just showing you where we are. We know you're just next to the lake, and we have 7 administrative sub-counties. Next slide. That's how they look like around the lake, and you see those places are, each sub-county has a facility that's supposed to be the go-to facility, what we call the county facilities, the referral facilities. And why I'm talking about this is because you cannot succeed if you don't have a proper primary healthcare structure. Some of these things happen because you have invested in structures which work. So once you've invested in the structures is what, when you can actually use them to get the results. And next slide. Kisumu is very lucky because we were one of the people who did community health. We took up community health, I think almost 4 or 5 years ago, trained community health workers, remunerated them, and gave them enough packages. And the second thing we did, even before elections, I think most of our community workers, health workers, were already digitized. Now, when your community health worker is digitized, I'm assuming all of you know how the health system is arranged. We have community units where a community health worker is in charge of 100 households and she has to register them. Now, when you register on these people on the platform, it means then that you have a database of everybody who is in that community unit. And we've taken a lot of advantage of that. Very useful information because then it tells you who is 25 years, who is a woman, who is a man, where do you live, and all those kind of things. So you can stratify your population and know the people. Now, those community health units are attached to facilities which you see in those peripheral classes. And what we've done is that in every ward, we have put up a facility, what we're calling a comprehensive primary healthcare facility, where we expect services to be always offered. What happens is that when you have a small facility, the one nurse, which is offering facilities this time and tomorrow is not offering facilities, you end up with people getting a loss to follow up or not coming back because they keep checking for you. So we have identified facilities that we make sure that these facilities always have that service available because we might not be able to do all those services in all those facilities. And that's what a primary care network is all about. What you've seen there is one of our sub-counties, and the facilities in the middle is the county referral hospital, the sub-county hospital, and the other facilities are the networks that supply that facility. Next slide. So back to cervical cancer screening. This is our population. Our population is 1.3 million. And so we estimate that around 44,000 women will be eligible for cervical cancer screening as per our guidelines. And that means between the age of 25 to 49 years should be able to be screened. Now, next slide. If you look at what WHO is calling on the community, the global community to eliminate cervical cancer screening, I want to look at the second and third targets. You know, the 90, 70, 90. The second target is that we want 70% of women to be screened with a high performance test. That's the target. Not any test, a high performance test by the age of 35 and again by the age of 45. And if you look at the last one, is that you want 90% of your women with pre-cancer to be treated. If you have cancer, you are treated. If you have pre-cancer, you are treated. And that is the call to action that WHO has given all of us. And this is what we are trying to do as Kisumu. If you look at those 44,000 women, we have assumed that 70% of them would be around 35,000. But we are aiming to do 8,000 tests with a high performance test every year for the next 5 years. So that by 2028, before the 2030, we will have screened every woman with a high performance test. The next slide. Now, if you look at this is the typical data that we get from our DHIS and KHIS, sorry. But if you look at this, it will tell you that in 2024, Kisumu actually screened 45,000 women. And that data is sometimes very deceiving because you might think that you're actually doing very well because you have 44,000 women and you have screened 45,000. So really, you have already hit your target. But if you look at those numbers in detail, you will find that 20,000 of those women are HIV positive women who get their screening every time. And we start screening HIV women from the time they get diagnosed. And we have quite a big number, the prevalence of 15%. We screen those women for as long as they come to the clinic, even up to 65 years of age. So then that 45,000 number becomes very deceiving. But again, looking at the slides, if you look at towards the right, you find that out of those 4,287 patients who had positive results, we treated 1,940. That's around 45%, meaning that we missed out on treating almost 50% of the people who deserved treatment. And again, this is a little bit biased data because we are doing a lot of HPV screening, and some of our protocols do not treat all positives. You know, a positive in this case means that you have a high risk positive. So sometimes then you have a step down or a second test which you're doing to determine whether you're going to treat or not. But some of our programs treat you based on that alone. So again, that data becomes difficult. Next slide. So this shows you the type of test that we are doing in Kisumu. If you look at the first row, that's in 2024, we did 4,000 HPV tests. We did 832 smears, and we did 33,000 VIAs. So the numbers that I'm more interested in are actually the first, because that's a high performance test, and the second one, which is the pap smear. So you can see that Kisumu has really adopted the strategy to move towards HPV screening with the bigger number of high performance tests actually being done being HPV. If you look between January to March, you will realize there's a big number. And that is the time when we did our community health campaign, and I'll talk to it shortly in my next slide, I hope. Let's go to the next slide. This is the treatment. Very important that we treat everybody. But you realize, again, we are doing around 45% treatments, and these are the challenges that I've talked about, that you might screen people and you find that they're positive, but then you tell them now you have to go to a room 16 in Kisumu County, the Kisumu town, which is 60 kilometers. You have to spend 300 shillings going, 300 shillings coming back. So even if the treatment is free, that access is not there for you. And that's what we are trying to do to make sure that the services are available in the periphery. I don't want to talk about that right now, because I think the national program has really supported us to make sure that some of those treatments are available in the periphery. But the human resource issues makes them not actually available, and many people still coming back to the central. But that's not my topic for today. You can see that we have in the cascade all types of treatments. We are doing lip. We did 48 lips. We're doing thermocoagulation. We did 1,000 thermocoagulation. And then we're doing surgery. That means hysterectomy, radical hysterectomy, cone biopsies in almost 110 of our women. Next slide. So what is it that we are doing differently? One, we had two models, and we've tried out. We are a place that does a lot of research, but I use one of the programs that I like most because the lady who accepted to fund us died in South Africa after she was shot by, and with her husband by robbers. But she listened to our story and said, maybe we can try out doing this HPV test. And we said we wanted to do community-based HPV screening. And what we did is we went to some communities. We again used community health workers. This is the first time we used community health workers. We gave them a list of women who are between 25 to 49 in the population, so that when you give the community health worker a target to go and bring people, you give them a list of names, not just anybody. Go and bring these people because they are registered on your community health system, and then bring them for screening on a certain day. So what we did is that we had a mobile, we are lucky that our partner bought a lorry that is cure cervical cancer. If you see behind there, there's a bus that is able to do HPV test within a number of hours. And so the women came to this screening. They were screened, and initially the samples were being taken by the nurses, but after a while we decided let it be self-collected. And then the samples would be taken to the bus, and then the bus would, the lab technology in the bus would test it, and then give you the results, and positive or negative, and then you treat. Now, when we use this model, we realized that we were doing an average of 50 clients in a day. That is 1 day service. You will go in and you get done with it. And of course, our treatment rates were very high because then you had the woman in front of you, around 80%. Of course, some people always refuse, say, I have to get permission from my husband and all those kind of things. The next slide. So the next model, we totally changed, and we were able to convince our partners that we can actually go out into the village. These people we are calling community health workers, who are not too educated, are actually well educated enough for them to go out in the community and give a woman a test to collect. Initially, we tried it just by training them and going out for them to talk to community members, but we realized we still had some samples which were being brought back which did not have anything. And so what we did is that we added a video for the community health worker, which was fed into their phone. So when they go out into the village, to the women, they discuss with the women, they talk to the women, and then they give them this sample. But before that, they show them the video. So that really improved our yield. And so what we do is what we would call cluster. You cluster a group of community units around a facility. You train those community health workers for 3 days, and then you give them these sample collection kits. You allow them to go out to the community, and then after a few days, they bring back all those samples. You test them, and then you schedule a day for them to come back for treatment. So you come back to the mobile clinic. A typical day we would do like in 5 days, you do 1,500 women, 2,000, depending on the number of community health workers you train. And then you link them to higher care depending whatever they were needed. So we do thermocoagulation on the spot in the community, but those ones who need LEAP or further treatment, they need to be referred back upwards. And I think this has been the most effective method. Go on, next slide. For us, because when we brought HPV self-collected sampling to the households, our yield per day is almost 700 samples in a day. So from 50 samples, when you go out to the community and tell people to come, to 700 samples, the initial fear that some of those women will be lost to follow-up, we dealt with them through a lot of interventions, because initially our treatment rate or return rate after we got HPV positive was 60%. But we've done several things to try and make sure that these things work. We have a call center where you can call in and question. We actually call you from the call center. The call center is toll-free, and they talk to you if you're positive. So your counseling is actually done by a nurse. And we have 4 nurses who are actually fully employed in the call center to be able to handle this kind of questions. Of course, we use them also for ambulance referrals. Next slide. I think I will end there. I think that is what we've been able to do in Kisumu. And with that, we are moving towards elimination, at least doing HPV high performance tests for each of the women. We've done 2 of our sub-counties, and I think we are doing the 3rd one in Nyando. By the end of this year, we should be doing another sub-county. And in the next 3 years, we should have done 7 sub-counties, all of them. One of the things that happens is that we have had to co-fund some of these things. We have to pay the community health worker stipends. But if you look at the return is much higher when you use this money. It looks like a lot of money when you're giving community health workers 1,000 shillings or 200 shillings. But the yield is very, very high. It actually makes a lot of sense. When we compared the time when we were going to the community and when community health workers were sent out with these things and came back with them, we're actually spending almost double when we were going out to the community to look for those, what we call campaigns. And that's why I'm not really a big fan of the campaigns, because the cost of a campaign in total, if you're doing HPV, is around 7,000 to 8,000 shillings per woman. And if you are doing it the other way around, it will going to cost you around 3,500 shillings. That is all inclusive. So we felt that this is a good thing, and that's what we are trying to roll out. Even when we are doing our VIA Villi, some of our programs don't use HPV, they do VIA Villi, but we do community unit by community unit. We go, we find out who are these people here so that we increase our coverage and not just the number of tests that we're doing. Thank you. I want to hand it over back to you.
Thank you, Dr. Ganda. Quite a story, quite something around possibilities. And the story is, it feels simple, it feels easy, but I'm sure you've done a lot of work to make it look like that. And I think this is something that the rest of the counties can look at and maybe see how they should be able to provide opportunities for the other women in the other counties. So still, while in Kisumu County, I really want to hear what Ms. Sela has to say. And Ms. Sela is the County Cervical Cancer Coordinator. I had introduced her earlier, but I want to focus mainly on some of the barriers that really work against us when it comes to uptake. And these barriers include cultural beliefs, misinformation, stigma. And I would like Ms. Sela to tell us some of the community-driven approaches that you have seen that are implementable to successfully tackle some of these challenges. Ms. Sela, welcome.
Thank you, Diana. Some of these barriers, actually, most of them are as a result of inadequate information within the community. The parents, teachers, the girls, and even young boys, as in Kisumu, that you have come across in the course of implementation of HPV vaccination, include myths such as HPV vaccination is a contraceptive, and as such, then it would increase sexual behavior in the young girls. Then the other question, which also leads to this, is why only girls? So why are we only giving vaccinating girls and not boys? Then there's also
We seem to have lost you, Ms. Sela. So I think
It seems she's having some connectivity challenges. What we could do, Dr. Elias Meli has joined us. He could jump in as we get Sela back.
it's Dr. I think it's the President Cogs.
Oh, sorry, Dr. Kireki.
Yes.
I'm sorry.
Yes, yes. So Dr. Kireki, I want to welcome you to this conversation. Thank you for joining us. I had introduced you earlier, but you, the president of the organization that houses providers for women around reproductive health issues, and we'd really like you to have this conversation with us. And what I want to put outside for you to actually tell us about what societies such as the COGS have done is we already have established screening guidelines, but our uptake is still low. How can societies such as COGS enhance awareness, adherence to care pathways, and follow-up for at-risk women? And I think while you answer the conversation around what COGS can do, would also look at the healthcare providers as key influencers when it comes to decision-making for the patient, and would like to hear from you how training and mentorship programs can improve the provider capacity to offer quality cervical cancer screening and treatment services. Welcome, Dr. Kireki.
Thank you. Thank you very much, Diana Marion. Thank you, everybody. Thank you, the conveners of this very, very important webinar. Thank you, the participants, the ones who are listening. And it is an important webinar. It, as we know, all of us, most probably, that January is the Cervical Cancer Awareness Month. My apologies for coming in a bit late. My flight got delayed and it's KQ, but we are here. We are here, thank God. Now, you've asked me two very difficult but important and pertinent questions. And the first one is the uptake is still low, and where can COGS come in as a society to enhance awareness, adherence to care pathways, and follow-up for at-risk women? First of all, let me say that the fact that we're here, all of us, starting with you, Dr. Diana Marion, Dr. Gregory Ganda, Dr. Barasa is also here. We are all obstetricians and gynecologists, first of all. And I want to thank you for the support that you give to the Kenyan Obstetrical and Gynecological Society. There's Professor Mungo is also here, who's also a member of our society. So the first thing that COGS is doing is what exactly we are doing right now. And I think this is something that is missing. and we sort of restrict it to the month of January only. We are spreading information. I'm sure in our participants, the ones who are listening, who have joined in to listen to these important conversations, there are a lot of them who may not have heard about our statistics as they were put forth by Dr. Melly, and also the good work that is being done in Kisumu by Dr. Ganda. So advocacy. What I would suggest, or what I was thinking in terms of advocacy, we as Kenyans, and I think most African countries, we don't have a culture of checkups. Because of whatever reason. They could be cultural. There is fear of going to the doctors. Maybe if they find something, what are they going to do? It's better to stay the way I am, such that whatever has been discovered, somehow it will go away. I don't think that is possible. So number one, I think we need to inculcate in our families, in our friends, the culture of checkup. Number two is information. Somebody said information. Once you have information is important. It will help you to make important decisions, especially about your health. Personally, I think this information should start right from primary school, because unfortunately we have adolescents, teenage pregnancy, teenagers who are getting pregnant, at 12, 13, 14, 15 years, meaning that they have started actually having intercourse. And we know that once they start having intercourse at that early age, most probably they will end up having multiple partners later on in life, which is a risk factor for cervical cancer. So advocacy. Number three, what some other countries have done, when you look at the European countries, especially Western Europe, what they did is they made it a must that every woman has to have a checkup, and amongst those checkups was then to have a pap smear. Of course, we know that now HPV testing is a lot better than the pap smear, but they were able to catch the women who are at risk, and these women were directed to the proper centers, and they were sorted out. So I think these are some of the things we need to do. Number two, we need to have linkages. In as much as we talk here about advocacy and so on, if we don't have money, it is not going to be possible to do anything. Just like what Dr. Ganda said, they calculated the amount of money, how much went to campaigns, and how much he used, or what was the cost when there was an all-inclusive sort of package. This money has to come from somewhere. So we need these linkages, and as it is said, he who has the purse strings actually is the one who calls the tune. So if we are not involving the financiers, the economists, and tell them, look, this is what this cervical cancer impact it has on our society and on the economic forum in general, we will not be able to do much. So we need to include our governors. We need to include, our CECs of health. They need to know, they need to understand how important this subject is, and how we can inbuild the mechanism of prevention rather than spending so much money later on, in treatment. Training is also part of it. And I'm very glad that Dr. Ganda is using the community health providers or community health workers to actually go to the houses where these women live, and actually do that process, get that process done in the comfort of these women's homes. These community health providers have been trained to a certain extent that they can actually help these women, or they can even do the HPV collection, and this is sent for analysis. So if we can be able to get more of these community health providers who can be able to help these women, or if not do that, they can also bring these women to where they can be tested. I think that will be a very big step towards prevention. And this is where as a society, we come in terms of guidelines that you mentioned. We need to update them, not to copy and paste from other countries. So this information needs to cascade down to the level of the community health workers, such that we may be able to make sure that prevention is actually taking place, and also whoever is diagnosed with this disease gets the highest quality of care. And that highest quality of care should be affordable, should be available, and should be accessible. This brings me to the second question that you asked in terms of training, that given that healthcare providers are key influencers in patient decisions, how can training and mentorship programs improve provider capacity? And this is where the training, where we have, occasional, and it should not only be occasional, but it should be something that is programmed into, for example, the training of medical students, the training of KMTC, midwives and nurses as well. So we need to train all the cadres, because all of these cadres will get in touch, or will be in touch with these women at one point or another. Now, that is for the general information, because we can use these cadres to spread information about advocacy. We can use these same cadres to collect the HPV, if possible, or train the women in collecting HPV samples. We can use these same cadres to direct these women to referral centers, and then now the tertiary institutions come into place, because now this is where we are training the subspecialists, amongst others, Dr. Ganda, who is one. You are also there, Dr. Diana, who will now see the very complicated cases and be able to provide the requisite care that is needed. Having said that, yesterday I was talking to somebody, I think from Tanzania, and they said they've been quarreling amongst themselves that they should have some subspecialty training programs in Tanzania. I'm not sure whether they have one or how many they do have. In Kenya, we are grateful that we have this training. We have the gynecology training, and we are training gynecologists in University of Nairobi and KNH. And we're also doing that at Moi Teaching and Referral Hospital and Moi University. So we do have these, we can say, super specialists who are able to take care of these women once they have been identified. But do we have enough of them? No, we don't have enough. The day when a woman in Mandera, Moyale, Migori, whichever of these, Isiolo, Marsabit, will have the same quality of care as a woman who goes to Aga Khan, for example, or hospital, a woman who goes to Nairobi Hospital, for example, and so on, these big private hospitals, then I think we can sit back and say, now we have reached the mountaintop. But unfortunately, we are not yet there, but we are making steps, and we are making these steps in the right direction. And then having said that, of course, as I said, we need to bring in the policymakers, because if a machine breaks down today, a radiotherapy machine breaks down today in KNH, for example, all those patients almost have nowhere to go. And remember, most of them come from different places. So their costs of transport, costs of accommodation, etc. So if it were possible, again, if we can think about having centers, super centers, where you have state-of-the-art equipment, as well as these super specialists who have been trained rigorously to handle these cases. And I think if we do all these things together, they can come in, fall into place nicely, so that we can be able to say we have actually reduced the number of deaths, preventable deaths from cervical cancer. Thank you.
Thank you, Dr. Kireki. Quite insightful. A lot of things to unbundle there, but maybe a call to the healthcare workers. Every single time you interact with a woman in your care, make the call for screening, make the call for vaccination. We make a difference everywhere we are, and all of us can make that difference. So as you interact with women in your train of care, this is in your antenatal clinics, this is in your outpatient facilities, and even as we interact even in the communities, including our churches, let's spread the information, let's spread the awareness. So I want to welcome Dr. Chemtai Mungo. And the key thing is around research. And we want to look at, I think one of the things we've seen is one of the greatest barriers is really trying to translate research into solutions. And I want to ask you, how can research institutions collaborate with local government? How can they collaborate with health providers to translate that cutting-edge research into real-world solutions that can actually benefit Kenyan women? And while you answer that, I also want you to really look at this self-administered HPV testing, very well explained by Dr. Ganda, thermal ablation for precancerous lesions. And I think he's mentioned the successes around it, showing that it's a promising approach to increasing cervical cancer management. How feasible are these in low resource settings such as Kenya? Welcome, Dr. Chemtai.
Thank you, Dr. Marian, and thank you everybody for joining. Like was mentioned, this is a critical topic, and it is, this is a cancer that we can prevent and eliminate. I'm a gynecologist, I'm a Kenyan. I did my medical training in the United States and did my residency there. And to illustrate the gravity of the problem, if you go to Kisumu here or, at Kenyatta, there's a ward that has women with cervical cancer, several. It's a very painful and dignified death. During the 4 years of medical school and 4 years of residency, I can count in my 5 fingers. Actually, my career as an obstetrician gynecologist, working in the US, I can count with my 5 fingers the number of women I've seen in the wards dying from cervical cancer. In fact, I know of one in the United States. And it's not because women are not having sex. It's not because there's no HPV. It's what we call the failure of the no-do gap. It's a no-do gap. We know several things about how to prevent this disease, but we are not doing it. Kisumu County is leading the way in closing that no-do gap. And we know that this is primarily a problem of poverty. So, if a woman has resources and can go to Aga Khan, her chances of dying from this disease is very different from a woman who relies on a functioning health system. So the key reason why I, as a gynecologist, has seen only one woman in my career of about 15 years dying from cervical cancer in the United States is because of a functional health system, because of a primary health system where we have very strong screening, where we inculcate amongst all of us that screening is important, and increasingly knowledge is becoming there. But how do we provide screening similar to what's happening in Kisumu County, where we have to go to women, make it easier for women to access screening? And then key is, for secondary prevention is then, linking screening to treatment. We all know about the WHO elimination guidelines or elimination agenda, or where really this is a cancer we can eliminate. And that, really all of us as gynecologists and healthcare workers, anytime we see a woman with cervical cancer, it is a failure of the health system, because we know even without vaccination that we can be able to screen and identify what we call a pre-malignant lesion that can be completely treatable. So we all have to, join hands and, spread and preach the message of vaccination, because that's the magic bullet. Countries that the vaccine, HPV vaccine is very safe. There's very good studies. Countries that vaccinated about 90% of girls 15 years ago now are seeing no cases of cervical cancer. So, we need to get at least 90% of our girls, because cervical cancer more affects women, vaccinated as soon as possible, as soon as yesterday, because then, the people who are now in nursing school, etc., or even, in 20 years, we can be in a world in Kenya where we don't see cervical cancer if our vaccination rates get to 90%. And then for everybody else who's never been vaccinated, screening works, because if you screen, and most importantly, you link to treatment. And increasingly, screening is getting better, especially with HPV self-collection. Like was demonstrated in Kisumu County. There's very good evidence that a sample that a woman collects, vaginal sample by herself, is very good to find HPV. So, with organized campaigns going to women, you can organize, working screening programs. And then most important, this is where the functioning health system comes in, is that you don't send a woman, 60 kilometers away to a clinic that's only open 1 day a week to get treated. We need to bring treatment closer to women. So I think the key issue is a functioning health system, advocacy. We need to get the HPV tests to be, very, very low cost and to be covered by health insurance. I know many people working in this area who are pushing for HPV testing to be available. There's very good data that thermal ablation, which many healthcare workers have seen, is a portable device. A lot of it, the Clinton Foundation provided it to many counties, almost 3 years ago. But the question is, are the thermal ablation devices being used? Because if you don't have a nurse that's trained, or if you have only one nurse that is also doing vaccinations, is also doing contraception, then imagine the woman who has, Mama Mboga, who has left her business to come to Kisumu or to come all the way to Thika, and then waits in line for 5 hours, and then she can't get treated. And then, she doesn't come back. And then in 7, 8 years, you see her with cancer that could have been prevented. So, having the thermal ablation machines, sometimes that's actually the easy part. The harder part is, how do we have functioning, robust health systems where there's enough healthcare workers, those who are trained, motivated to stay there. We bring down costs, so we have, get services closer to women, so that women don't need to go to referral centers, because we know that anytime you send a woman out to referral center, especially the poorest women, are not going to make it. There's a lot of opportunity for us to make a difference, and let us all put our hands and heads together. Vaccination works. Let's fight those myths. Let's get girls and boys too. The priority is girls because of the dire consequence of cervical cancer, but in boys as well. We can get them vaccinated now. We have very good evidence that just one dose of the vaccine is effective. So really, our goal as a country should be in the next 3 years to get to 90% of vaccination, because then that takes care of the future. And then for all the women, our mothers, our daughters, screening and really investing in health systems, because if the health system is not working, then you keep having these issues of preventable deaths. So thank you for having me. Happy to answer questions.
Thank you, Dr. Chemtai. I think hope is what we see when we have evidence saying that at this point in time, even one dose of the vaccine is adequate. Evidence saying that screening is what we need to go for if we can't access vaccination. Vaccination is important to the girls and even to the boys, and we need to get that conversation going, and research is done so that we can keep on improving on the various areas that we need to improve. So thank you very much. And I really want to appreciate all of us. So just to move on to the next session, I want to give this back to Dr. Diana Wangari so that you can take us on with the rest of the program. Thank you.
Thank you, Dr. Diana Marion. And thank you for the panelists for the insightful presentations. I'll move on to some of the questions that have come in from the participants. And I think we'll start off with some of the questions that have been addressed to Kisumu County. If Ms. Sela is in. If not, I'll raise one question since Dr. Chemtai, you're still on. The question that has been asked, is there any ongoing research on local risk factors for cervical cancer in the region?
Yeah, that's an excellent question. The reason why cervical cancer can be prevented and even eliminated is the key thing that causes these abnormal changes in the cervix that then become cervical cancer is infection with human papillomavirus. So, we have the scientists who made that discovery got the Nobel Prize, the highest honor. So, HPV vaccination is the key. HPV infection is a key cause. So, there's not good evidence that, there's anything else that's happening. HPV infection is very common. In fact, 90% of us will get exposed to it. So, HPV is a main thing that causes cervical cancer. So, when smoking will make you less likely to clear HPV. So really the scientific question of why has been answered. It's a HPV infection, and HPV is like the cold, Japata homa when it's cold. It's just a normal virus, but persistent infection when it stays in the body for a while is what then will cause this. But we know we can prevent it primarily through vaccination, and secondly through screening to find those changes. So yes, the research that we need to do is how do we get the scientific knowledge that we have into reality? How do we translate it into reality? Dr. Ganda, I don't know if you want to add anything.
Yes.
No, I will not add anything to what you've said. I think you're okay.
Okay, Dr. Ganda, since we have you, we've seen from the chats and even the Q&A, a lot of people saying it's quite a commendable job that Kisumu County and the team led by yourself are doing. They're doing quite well, and they're thankful for the elaborate and in-depth presentation. There's a question here that might be very specific, but I'll go ahead and ask. Can you, thank you, Dr. Ganda, for the insightful presentation. Can you share insights on the proportion of patients out of the 1940 who are successfully treated on the same day under the screen and treat model? And what strategies were used to address any barriers to the same day treatment?
Thank you. I think I've seen quite a number of questions about that and about the follow-up. And that's why we're talking about whatever we are doing, we are incorporating it into the health system. So that when we are going to a community, you are a community unit and you have a link facility. When we finish, then we tell you where you will go back for review in your link facility. So that if your link facility does not have capacity, then they'll refer you upwards. So I think that is a strategy that we've used to ensure that even after we've gone away, you can still be followed up. But finally, we have a call center that is available to you. It is toll-free. It always has a nurse. It's 24 hours actually, but usually in the evenings, you will not find a nurse. So if you call during the day, you will find a nurse. But if you call in the evening, we will get your number and the nurse will call you during the day, just so that you can be able to be advised on what you need to do. The barriers, I think Sela should have talked about it, but there are many things. It's about educating the community over and over again. We were just doing one of our programs, just sharing with us about community health workers in one of my sub-counties with the other. And we did a pre-test on both of them because we were doing something slightly different, HPV vaccination. you find that where the program has passed, the average score on the pre-test was 80 to 90%, even after the post-test, 80 to 90% to 100. But in other places where they've not gone, you find even after teaching, you still get 40 or 50%. So it's about how many times can you talk about it? How many times can you explain? And that's the same thing that's happening if the community health worker is having a problem understanding what you're talking about on your first instance. Then the same thing with the community. So over and over, we have many, many campaigns. We've had the scrub campaigns, we've had radio talks, we've had community workers go into the villages. There's so much talking about cervical cancer, and that was led actually by the politicians. The first ladies of the Lake Region Economic Bloc took it upon themselves. They were on the radio. They were having so many campaigns. And when you see some of these top politicians, they excite people. People want to know what is it that they're talking about. We have posters with the first lady talking about cervical cancer. So many things to make sure that this information actually is passed on to the members of the community, just to break those barriers or fears that we have. Thank you.
Thank you, Dr. Gregory, for that. I know we have a few more questions on Kisumu County, which I'll come back to. I think there's a question for Dr. Elias Meli here around NCI. So are there plans to incorporate the cervical cancer program? Is there potential for including boys in the national vaccination plan? And I think that ties to many questions that have come up around the inclusion of boys in most of the campaigns and the national programs, including in schools and high schools as well. So maybe you could address it from a broader gender perspective.
Well, thank you very much, Wangari, for passing over that question. I want to begin by also appreciating that this has been quite an insightful session. The government's Ministry of Health leads in policy and making sure that there are initiatives which would address a public health problem that is quite a challenge in the country. So we know we have successfully, or we are making a lot of progress in HPV vaccination amongst our girls and our women who are eligible for vaccination. This question about vaccinating men has been, our boys has been lingering for quite a while. We know that there is no policy guideline currently in our country to vaccinate our boys, but we know there is also HPV-associated cancers amongst men, and there is sufficient data, on other than cervical cancer. We have head and neck cancers, we have, anal cancers, testicular cancers, which there has been direct linkage between HPV infection and cancer causation. So to answer the question specifically, we do not have a policy directive yet. Probably it will come sometime in future as we gather more data to demonstrate that if we are going to vaccinate our boys, then down the stream, there is sufficient evidence that it actually prevents, the causation of these cancers that are associated with HPV. Remember, colleagues and friends, that cancer causation is multifactorial. It is not one, particular cause. There has to be other drivers. So as we have demonstrated that 99.7% of cervical cancer is caused by HPV, there are that small percentage that is caused by other factors that might not have been confirmed what causes the mutation. So amongst men who have HPV-associated cancers, there is no tangible evidence that the most of it is because of HPV. There could be other, factors that we still need to confirm from research to give us evidence to, develop a policy that will be rolled across the country. I have also seen a few questions that I would wish to react to on infrastructure for treatment of cancer through the national government, if you may allow me to respond to that as well. Working towards achieving our 70-90 elimination strategy for cervical cancer, the third pillar, which is treatment, I know we've talked about screening a lot, and we know right now the standard of care is HPV screening. There are challenges, with the other modalities of screening that we've used before that have been deployed. And right now, though expensive, we are encouraging, since its sensitivity and specificity is high, to consider, HPV as the standard of care. But in some settings, we know VIA test is still undertaken. Some people still do pap smears, despite the challenges that we know do exist with the lower specificities and sensitivities. Allow me to also then mention that in the treatment, part of 90% of those who are diagnosed with premalignant and invasive diseases should be treated. The government, through Ministry of Health, has created capacity through regional cancer centers and the national referral hospitals to comprehensively treat these patients through surgery, systemic treatment with chemotherapy or targeted therapies or immunotherapy, as well as radiotherapy, external beam radiation, and brachytherapy. We know we are working hard currently as an agency that leads in implementation of cancer agenda in the country to make sure that we increase access by making sure we address our disparities and inequities by making sure across board we are able to have, the public access care close home. The investment into comprehensive cancer centers is capital intense. Therefore, we cannot afford to have that center in every county government. So the strategy of regional cancer centers is the best approach. We have Garissa, Mombasa, Nakuru, and now working on making sure the Kisumu Center, which I know my good friend, Dr. Ganda, we've had many discussions to make sure that center is completed to provide radiotherapy services. We hope this will be done soon. And also in Kakamega, the Kisi project is coming on, and also working on Meru and Nyeri. Those are the centers which are earmarked. So to whoever is asking, the western part of the country, MTRH currently is serving that entire region. We know there is a challenge. And as we invest infrastructure in treating, one type of cancer, fortunately, this is a shared resource and all the other cancers will benefit. So watch this space. We are advocating for more resources into the cancer space domestically through our National Assembly, and also linkages to grants and support from partners locally and internationally. Thank you, Wangari.
Thank you so much, Dr. Melly. I know we are out of time, but I'm kindly requesting the participants if you could just give us 10 more minutes. We want to address, I think, one important question that has come in, and also have closing remarks from the secret guest who's joining the panel. And then Dr. Chemtai is also willing to remain behind in case there are additional questions. I think Dr. Gregory Ganda, a lot of the questions that came in beyond Kisumu were very much gynecologist related. And I think some of those questions very particularly, I think were also tied to the question around gender. So I think maybe I could ask this as a follow-up to what Dr. Melly said. Dr. Chemtai, Thanks for the insight. Please confirm that in the US, HPV vaccine is given to both boys and girls, and not to girls not only to girls. Is this the case? And what do you think that policymakers need to? I believe the policymakers can prioritize the prevention by planning for more funds. It wasn't really a question, but maybe you can confirm that in the US, the HPV vaccine is administered to both boys and girls, and what were the benefits?
Yeah, so absolutely, the vaccine is licensed for both genders. And if cost was not an issue, should be given to both genders. So for example, private insurance should cover it for both genders. As was mentioned, the reason why it's being prioritized to girls in Kenya and many countries like Kenya is that resources are not infinite. So, you still have to prevent malaria, you still have to pay for XYZ. So from a public health perspective, you choose where to put your money so that you can have the biggest bang for your buck, as they say, the biggest impact. And based on the fact that penile cancer is not as common, so vaccinating girls is a priority from a public health perspective, because if you go to the ward, cervical cancer is the second most common cause of cancer for women, and it's completely preventable. So I hope people understand that reasoning. It's a public health decision because, money is not infinite. But the biology is such that you want to treat both men and women, and boys and girls. You want to vaccinate both. But from a public health perspective, the vaccine is free for girls because they're the most impacted. But in the private sector, both boys and girls can be vaccinated, and we should advocate that private insurance should cover both, because private insurance has more bandwidth for spending compared to the public health sector. So yes, in the US, both genders are vaccinated, but then we can't compare the budget of the US health system to Kenya. So that's why.
Thank you so much for giving the text, Gregory.
Yeah, maybe I can add on. I think there was a study done by Nyangasi and the team from the NCCP. I think it was published last year on the cost of actually the HPV vaccination. And the issue is that it costs around 300,000 shillings for every cancer we prevent if we are going to vaccinate girls. Now, it's not cost effective to vaccinate boys because the purpose of vaccinating boys is not to prevent cervical cancer, really. In the US, the number one reason for vaccinating boys is actually the cancers of the head and neck, as Dr. Melia talked about, not cervical cancer. And the second reason would be the penile cancers and all that. So if you are having a cancer that is number one in terms of women after breast, then you want to target that cancer. So vaccinating boys in the name of trying to prevent cancer is extremely expensive because you would be spending maybe around 2 million shillings to prevent one cancer, which is not cost effective for an economy like ours. Thank you.
Thank you so much for that, Dr. Gregory. I think we're still trying to get our closing remarks, but some of the insights, and I hope my co-moderator, Dr. Marion, is here as well. Some of the insights that we've gotten from here, I think, again, very good, commendable efforts from Kisumu County. Bridging that access gap by going to the community and ensuring that it's a comprehensive team. I think we've seen comments around that the incorporation from community health promoters and other cadres of healthcare workers is critical. And the fact that they have invested in this as the county, and it is giving returns. I think we've seen comments from in the chat as well, commending Dr. Elias Melly for even the mindset around no woman should die from cervical cancer, and the work that NCI is doing and working towards that. I think Dr. Chemtai, even just trying to localize the data, there's been a lot of commendations around that as well. And same, we hope that the work does continue around getting local data as well. I know Dr. Kireki as well, those recommendations around how do we build a culture of checkups. And it starts with advocacy. It starts with you. It starts by you saying, has your mother, has your sister, has your wife been screened as well? So there's commendations around that as well. I don't know if Dr. Dana Marion, you have other comments. I've just been reading the commendations from people in the chat. If you have some comments as well, go ahead and then we'll be wrapping up.
I think just to bring some clarity around questions asked if you can get the vaccine after exposure. Yes, you can get the vaccine after exposure. It just needs to be clear to you that it will not prevent what you already have or what you have interacted with, but it will prevent the severity of or the severity of the outcomes of the infection. It will also prevent you from getting what you the serotype that you already don't have. So it's actually recommended that women up to the age of 45 can get this vaccine. So even after the sexual exposure, it's good that we know that this is a vaccine that is accessible also to those that are sexually active. So that is something I would like to put out there. The second thing is let's look at what we have in the country in terms of resources, and let us reach out from where we are so that we can encourage. A lot of our women attend our antenatal clinics, and it's one of the conversations we can have with our antenatal mothers around issues to do with screening and around issues to do with HPV vaccine, which can actually be given postpartum. So yeah, that is what I would like to add.
So Diana, you're muted.
Dr. Kireki,
Yeah.
are you still there for final comments?
Yes, thank you once again. And I think this has been a very good discussion. And as I said, and we'll continue saying, it's a mantra which we should continue using: prevention, prevention, prevention. And all the women that we get in touch with, we should ask actually that question: when is the last time you had a test? And then from there, we take it from there. So I think by doing this, we will sort of get a dent on the numbers that we are having, which are horrible. And hopefully with time, we shall be able to kill this monster. Thank you.
Thank you so much, Dr. Kireki, for that. We were hoping to get the president of the Kenya Medical Association to close for us, but I see we have some challenges with that. I'd like to say thank you to everyone for joining us. I know there's, Dr. Kigondo, you're here. Maybe you can close for us. I was about to take the honors, but I'll hand it back to you. For everyone else, questions which haven't been answered, Dr. Chimtai will also remain after this to answer those questions. And thank you so much for joining us. Dr. Kigondo, if you could close for us. Dr. Kigondo? You're on mute, we can't hear you. Dr. Marion, we might have to leave it to you.
I think the issue is around him getting in as a panelist, but I think he can unmute. Dr. Kigondo, you can unmute. I don't know if he can hear us. Okay, so I think I really want to appreciate the panelists for taking time to join us. This has been very informative. We want to call more engagements even as the month is coming to an end. I think awareness doesn't stop with the month of January. This is a conversation we need to keep going. I really want to get to that point where I can count fingers the way Dr. Chemtai said she's counting fingers of how many patients are dying in the US from cervical cancer. Us is not fingers. Us, we have real numbers and very scary at that. These are communities and these are families that are losing mothers. So I think we need to look at really how we can get this going. So Dr. Melly, please, let's get it from policy, let's get it from stakeholders that really influence this, including budgets. Let's look at even treatment. Let's look at those investments, infrastructure, and let's get there. Let's keep this wheel moving, and I think we can get where Dr. Chemtai is at, and that will be a very good story. So with that said, I really want to thank all the participants for creating time to be here. Let's spread this information, let's create awareness, and let's remember that knowledge around issues to do with reproductive health for our women is very important. And the more we speak about it, the more our women are able to understand how they need to take this right into their own hands. So I really want to appreciate all of you. With that, I think I want to close this meeting and appreciate you all. Thank you.
Thank you very much.
Bye-bye. Good evening. Till
Thank
next
you.
time.
Good evening.
Bye.
Bye.
Bye. Thank you.